asthma flare-ups, attacks, exacerbations. These terms all describe the same thing: a sudden or gradual worsening of asthma symptoms such as wheeze, chest tightness, shortness of breath, coughing, and a measurable drop in lung function, typically due to increased airway inflammation and bronchoconstriction. Fortunately, most exacerbations are preceded by subtle clinical changes, called the prodromal phase. About 10 to 14 days before an exacerbation, underlying inflammation steadily builds, leading to a gradual decline in peak expiratory flow and a rise in everyday symptoms. Patients often notice new cough and chest tightness during routine activities and may start using their reliever inhaler more frequently. The time frame leading up to an exacerbation may represent a window of opportunity to minimize airway inflammation and either prevent or reduce the exacerbation by initiating corticosteroid-containing anti-inflammatory therapy if the patient is not already using it, stepping up the current anti-inflammatory dose, or switching from GINA Track 2 to GINA Track 1. Ideally, patients will follow GINA Track 1, which involves using a single inhaler with low-dose inhaled corticosteroid ICS formoterol as both controller and reliever therapy. This is referred to as anti-inflammatory reliever (AIR) when used as needed, and as maintenance and reliever therapy (MART) when used both daily and as needed. Alternatively, patients may follow GINA Track 2, which uses a separate ICS-containing controller inhaler alongside a short-acting beta-2 agonist SABA reliever inhaler. GINA advises Track 1 for reducing severe exacerbations risk, as ICS formoterol offers anti-inflammatory benefits and lowers the risk of severe exacerbations and hospital visits compared to SABA-only treatment or daily ICS plus SABA. When an exacerbation occurs, it signals that asthma is acutely no longer well controlled, and if not managed promptly, it can lead to hospitalization and long-term damage to the lungs. Initial assessment and management upon presentation begin by assessing whether the clinical presentation matches asthma. Is this asthma? Are there risk factors for asthma-related death? And what is the severity of the current exacerbation based on the worst clinical feature observed? In mild or moderate exacerbations, patients typically speak in phrases, prefer sitting upright to lying down, are not agitated, and though having an increased respiratory rate, it is under 30 breaths per minute, pulse below 120 beats per minute, SpO2, oxygen saturation between 90 and 95%, and a peak expiratory flow, PEF, above 50% of predicted or personal best. In these cases, start bronchodilation with rapid-acting beta agonist, such as salbutamol, via PMDI plus spacer, 4 to 10 puffs every 20 minutes for the first hour. And prescribe oral corticosteroids. For adults, prednisolone 50 mg once daily for 5 to 7 days. Supply controlled oxygen if available, targeting 93 to 95% SpO2. For a moderately severe exacerbation, add inhaled ipratropium bromide. 4 puffs, 20 micrograms per actuation, every 20 minutes for 3 doses if needed. Reassessment. After 1 hour, after the first hour of treatment, reassess the patient's response. If symptoms have improved and PEF has risen above 80% of best, the SpO2 is greater than 94% on room air, and there is no need for further emergent bronchodilator doses. Then continue SABA treatment as needed, and prepare to complete the visit. Completing the visit upon improvement. Ensure improvement before sending the patient home. No SABA has been needed in the past hour. PEF improvement is greater than 60 to 80% of personal best or predicted. Oxygen saturation is greater than 94 on room air, and the patient has adequate support at home. After an exacerbation, always follow a structured approach to send patients home, which must include a written asthma action plan, review and adjustment of controller and potentially reliever therapy, reinforcement of inhaler technique and adherence, complete a fixed short course of oral corticosteroids, such as prednisolone, usually 5 to 7 days for adults, and follow-up in 2 to 7 days. Addressing severe and life-threatening presentations. If the patient's condition worsens at any point, defined by persistent low PEF, oxygen desaturation, or escalating symptoms, facilitate transfer to acute care without delay. Time spent before treatment escalation can mean the difference between a rapid recovery and a life-threatening crisis. Severe exacerbations present with speech limited to single words, use of accessory muscles, respiratory rate over 30, pulse above 120, oxygen saturation below 90%, and PEF under 50% of best or predicted. Patients are agitated and often sit hunched forwards. A life-threatening exacerbation presents with drowsiness, confusion, or silent chest. These are pre-arrest signs and demand immediate transfer to an acute care facility with administration of SABA, ipratropium bromide, controlled oxygen to keep SpO2 between 93 to 95%, and systemic corticosteroids. Emergency room management can consider additional therapies such as intravenous magnesium sulfate for patients with severe exacerbations not responding to initial treatment. Follow-up and preventing future events. Finally, at follow-up within 2 to 7 days, assess whether oral corticosteroids are still indicated based on a review of resolving symptoms and signs. Controller medication should be continued at high dose for weeks to months depending on the etiology and nature of the exacerbation and the individualized patient risk of death. For patients using separate inhalers for controller and reliever, consider switching treatment regimen to GINA Track 1, consisting of a combination of ICS formoterol as a single inhaler for control and relief. Risk factors should be identified and addressed, and those that are modifiable, corrected, including inhaler technique and adherence, comorbidities, and environmental exposures. Referral to a specialist is warranted upon exacerbations more frequent than 1 to 2 a year. A well-understood, personalized asthma action plan empowers patients to recognize early warning signs, manage flare-ups effectively, and seek help promptly, reducing hospital visits and preserving lung function. In summary, asthma exacerbations can often be anticipated, promptly treated, and, most importantly, prevented. Timely recognition, appropriate pharmacological response, and structured follow-up are the foundation of good exacerbation management. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.